Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. So to better understand tocolytics, we need to first talk about the uterus. The uterus is a muscle, and the baby grows within the muscle during pregnancy, and the muscle expands to facilitate this. At the end of pregnancy, the muscle then contracts for labor and birth, and then ultimately to control bleeding after delivery and in the postpartum period. There are times, however, that the contractions from the uterus can be harmful. This can be in cases of preterm labor if the baby is less than 37 weeks gestation, and also during labor if we're having non-reassuring fetal heart tracings, often because that the uterus is contracting too much. So then we need to consider how we can decrease the contractility of the uterus. So tocolytics are going to be the way that we can do that. Tocolytics are medications that decrease the contractility of the uterus, or it relaxes the muscle. And this is going to help to slow or stop uterine contractions. There's four main medications we use as tocolytics. One is Indocin, one is Nifedipine, one is Magnesium Sulfate, and the last one is Terbutaline. So these are going to relax the uterus and also help to stop or slow preterm labor. So for preterm labor, we're thinking about contractions that are causing cervical change prior to 37 weeks gestation. So we're seeing dilation and effacement, and contractions are consistent. So a tocolytic may be used to extend the time before delivery. Tocolytics don't generally stop labor completely, but they can buy us time. And in preterm labor, time is important because we may want to give corticosteroids like betamethasone to help promote fetal lung maturation. We might want to give antibiotics because it's going to help protect the baby. We don't know if she's group B strep positive. There might be infection that's causing preterm labor. So there's a lot of reasons to give antibiotics. And then also we can use tocolytic magnesium sulfate for neuroprotection, which we're going to talk about in a second, which helps protect the baby's brain when they're born early. So the other reason for tocolytics is non-reassuring fetal heart tracing. So here's an example of late decelerations. We can also see like prolonged decelerations as well. If we're seeing fetal heart tracing that's not reassuring, often with late and prolonged decelerations, we are concerned about the oxygenation to the baby, which can cause a brain injury and hypoxia. So tocolytic medications can increase the perfusion to the placenta by decreasing contractions. So what happens here with the tocolytic is it can slow the contractions down and give time to increase perfusion to the placenta. So the acronym It's Not My Time is a way we can remember the four medications that we use for this. I is for Indocin, N is for Nifedipine, M is for magnesium, and T is for Terbutaline. So let's look first at Indocin or indomethacin. Indocin is a nonsteroidal anti-inflammatory drug. And so it's in the same family as ibuprofen. And we teach pregnant women not to take ibuprofen during pregnancy. And this is because of the side effect that even Indocin can have, which affects the baby's heart. This drug is going to inhibit prostaglandin, which ultimately decreases contractions very effectively. We can typically only use it for about 48 hours, and we will not use it if she is greater than 32 weeks gestation. So this is a drug for if we're less than 32 weeks gestation. And the reason that we're concerned about the gestational age with this drug is because that this medication can cause a premature closure of the ductus arteriosus. The other side effect is for the mother, and that is going to be a GI upset like nausea, vomiting, heartburn, things like that. So the biggest concern is going to be for the fetus with this drug. And so with the baby's heart, This little path right here is the ductus arteriosus. The ductus arteriosus is one of the shunts in the fetal heart because the blood comes in already oxygenated through the umbilical cord and it bypasses the lungs. It doesn't need to go to the lungs for oxygenation. So the blood that's coming up that is en route to the lungs instead goes through the ductus arteriosus and through the aorta and out to the body. If we cause a closure of this spot or a constriction, that's going to be a problem for the baby. So this is why we're not wanting to use Indocin if we're after 32 weeks. The next drug is Nifedipine, also known as Procardia. Nifedipine is a calcium channel blocker, so it inhibits calcium from entering the smooth muscle, and that's how it works for blood pressure, but it also works that way on the smooth muscle of the uterus. It can be immediate release or extended release tabs. It's contraindicated if she has an intrauterine infection, and the biggest side effect for Nifedipine is hypotension because it's a calcium channel blocker. So this is a drug that we need to know what her blood pressure is before we give the medication. And then we need to watch for dizziness, low blood pressure, orthostatic hypotension, things like that. This medication also can cause a headache. The next one, or the M, is magnesium sulfate. So magnesium sulfate is a drug that we use to treat patients with preeclampsia. It's a central nervous system depressant that prevents seizures for preeclamptic patients. But it also decreases the contractility of the uterus. It relaxes the smooth muscle of the uterus. And so for this reason, it helps buy us some time, again, for betamethasone antibiotics. And it has an additional benefit because it also provides neuroprotection for the fetus. So especially for a baby that is less than 32 weeks gestation, the vessels in the brain are very small, and the magnesium sulfate is going to help protect the baby's brain. We give this for 24 to 48 hours. And then we have to monitor closely for signs of toxicity. So with magnesium sulfate, because it's a central nervous system depressant, it can slow everything down. We can see respiratory depression, absent deep tendon reflexes, decreased urine output, extreme muscle weakness. And so we are needing to very closely monitor for these signs and to discontinue and potentially give the antidote, which is calcium gluconate, if we see signs of magnesium toxicity. And then the last drug is the T, Terbutaline. Terbutaline is going to be a medication that we use especially for those non-reassuring fetal heart tracings because it works very quickly. It's dosed as 0.25 milligrams as a subcutaneous injection. It's going to relax the smooth muscle and inhibit uterine activity, and it happens very quickly. So it's going to be the choice if we're having tachysystole. Tachy is fast, systole is contraction. If we're having a lot of contractions and we're seeing prolonged decelerations and we're concerned about the baby, this is going to be the tocolytic to use. Terbutaline has a side effect where it affects the heart. It causes tachycardia and sometimes palpitations. So it's important not only to educate your patient that they might feel like their heart is racing, but also to know what her heart rate is before you administer the medication. So knowing vital signs for all of these medications is helpful, but especially with terbutaline and nifedipine. So again, it's not my time. I is Indocin, N is nifedipine, M is magnesium, and T is terbutaline. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.